Hello, everybody, and welcome to the IOCDF Research Roundtable, the only IOCDF stream where we pick an interesting topic within the OCD literature and talk about it with the folks that know it best. My name is Kyle King. I'm a first-year medical student at the Yale School of Medicine. I'm an IOCDF advocate, and more importantly than both those things, I'm someone who has struggled with OCD for the majority of his life. So a lot of the things that we talk about on this stream are really relevant to me. I've also dealt with an eating disorder in the past, and have been diagnosed with BDD. So this stream is going to be relevant to me too. I kind of just gave away the topic of the stream. We're going to be talking about BDD with our panel today. And for people who have viewed this stream before, they may recognize us talking about BDD and recognize many of the faces on our panel today. We did indeed talk about BDD earlier this year. BDD is body dysmorphic disorder. I just jumped into using an acronym. We talked about it earlier this year, but we were going back over the stream and we saw that there was a lot that we didn't really have time to discuss. Body dysmorphic disorder is a complicated and interesting topic, and it's pertinent to a lot of folks with OCD. And there's a whole field of literature in and of itself unrelated to kind of its relationships with OCD. So we wanted to kind of bring the gang back onto the stream and get more in depth with some more complicated topics and kind of go over some of the things that I didn't understand when I watched the stream again. I will go ahead and introduce the whole panel. Unfortunately, my co-host John Bromwoods couldn't make it today. So hi, John, if you're watching after the fact. But before I introduce the panel, I do have a couple disclaimers to go over. First, this live stream is intended to serve as educational content only and is not intended to replace therapy. For treatment-related questions, please be sure to work with your local provider or contact a local clinician. The International OCD Foundation is not a crisis hotline and should not be used if you are in distress or feel unsafe. If you're in a crisis or if you're ever feeling suicidal or unsafe, please go to your local emergency room, call 911, or call the Suicide Prevention Hotline at 800-273-8255. Also, we want to create as safe a space as possible and be kind and respect everyone. With that, this is being broadcast on various social media platforms and is being recorded. So please be mindful of that as you ask personal questions or leave comments. At the end of the day, we're all here to support one another. Kind of going off that, this is a live stream and there's a comment section. We do really encourage you to put in questions, and I will pepper in your questions to our panelist of experts as the stream goes along. Also, the IOCDF is offering research grants to scientists who are investigating OCD and related disorders. More than $1.5 million in research funding is available, and proposals are currently being accepted. So please be sure to submit yours, or at least check out the proposal process at iocdf.org/research. Okay, so those are all my announcements. Now I think it's time to start introducing the panel that we have today. The first guest, I'm going to focus in on the person. And I just got a private message from the person who oversees the stream. The research proposals can be submitted starting January 6th. Okay, cool. But the research, wait, I'll circle back to that at the end of the stream. Boris, if you could clear up in the comments what exactly you mean. So starting with our first panelist, Dr. Jamie Feusner. Dr. Jamie Feusner is a professor of psychiatry at the University of Toronto, a senior scientist at the Center of Addiction and Mental Health, and foreign adjunct professor at the Karolinska Institute. As director of the Brain, Body, and Perception Research Program, he conducts clinical neuroscience research on perception, emotion, and reward across conditions involving body image and obsessions and compulsions, such as body dysmorphic disorder, eating disorder, and OCD. Dr. Feusner conducted the first functional brain imaging studies in BDD and has over 20 years of clinical experience treating BDD. He also serves as the vice chair of the International OCD Foundation Scientific and Clinical Advisory Board and is chief medical officer at NoCD. Dr. Feusner, it's great to have you on today's stream. We talked about your research for about half of the last stream, so it's good to have you on. And as I prepped you for, I have a silly intro question. What is your favorite movie that came out after I was born? So after 2001.
Oh boy.
Yeah, you can't reach back into childhood for this one.
My favorite movie. Oh. All right, I'm going with Barbie.
Barbie. Okay.
Barbie.
I saw the back half of Barbie. Why do you pick that one?
Because I just want to move on to the next person. That's the first thing that came to my mind.
Okay, fair enough. I should have given you more time to think about it. I'm sorry, Dr. Feusner.
I'll think about it, maybe come back to me.
Okay. Our second panelist is Dr. Katharine Phillips. Dr. Phillips is a professor of psychiatry, DeWitt Wallace Senior Scholar, and residency research director at Weill Cornell Medical College, and attending psychiatrist at New York Presbyterian Hospital. Dr. Phillips is internationally recognized for her clinical and research expertise in body dysmorphic disorder and OCD. She has been conducting research studies and treating patients with BDD for more than 30 years. She has published most of the medication studies on BDD and has co-developed and tested CBT for BDD. She has published more than 365 articles, one for each day in a year, and chapters in scientific journals and books. And she has authored or edited 11 books, including multiple books on BDD. Her awards for her research studies on BDD include special presidential commendations from the American Psychiatric Association and the 2023 Outstanding Career Achievement Award from the International OCD Foundation. Dr. Phillips, same question goes to you. Best movie that you've seen since 2001?
Oh, dear. You know, I love the question because I like to watch movies, but it's really hard to choose the best. I'm just going to say I don't actually know when it was made, so I don't know if it's since 2001 or not.
Okay,
I really like The English Patient. I thought that was just a really wonderful, very, very moving film, wonderful actors, but I don't know when it was made.
All right, 1996.
Oh, I missed it by 5 years. Okay, 5 years.
I did not expect this to be a difficult question, but so far we're open to it with our panelists.
Hard. Let me just say, when I was in medical school, I saw no movies at all. So that was the 1980s. That was my lost decade because I had to study so hard.
Okay, well, don't worry. I'm not going to have time to watch anything you recommend.
That's not an excuse because you're asking since 2001. I think I'm going to do what Dr. Feusner did and ask if I can think about it a little more.
Okay. We'll just do all of the intro stuff at the end this time.
Down the road.
Our third panelist, and hopefully someone who can answer my question, is Dr. Chris Trondsen, or just Chris Trondsen. Chris Trondsen, LMFT, is an OCD and BDD clinician at the Gateway Institute in Costa Mesa, California, Vice President of OCD Southern California, leader of the IOCDF's BDD and LGBTQ+ special interest groups, and a member of the IOCDF Board of Directors. Since childhood, Chris suffered from undiagnosed severe OCD, BDD, major depressive disorder, and anxiety and panic attacks, only receiving formal diagnosis and specialized treatment in his early 20s. Chris began advocating publicly for mental health and shared his story of recovery on TV shows and various newspapers and websites. Chris began speaking at the annual OCD conferences, giving the keynote speech with his mom in 2011, and helped start the conference's young adult track. As a lead advocate, Chris's passions include expanding BDD awareness and education, addressing LGBTQ+ issues and mental health treatment, and expanding the IOCDF services to the young adult community. He's also my biggest advocacy mentor. Chris, question goes out to you. Best movie you've seen since 2001?
Yeah, so my favorite movie since 2001 is Minority Report. It was directed by Steven Spielberg. It starred Tom Cruise. And part of the reason I like it is it's a kind of futuristic world where they can predict crimes before they happen. But a deeper psychological message is, if we could, do people have free will? Can people make a change last minute? Should we predict factors of human behavior? So the psych nerd in me liked it. But yeah, it was my favorite Tom Cruise film, Steven Spielberg. So.
Also, love the speed at which you answered that question. You just drilled down right into it.
He had more time to think about it.
You didn't have more time. You had an advantage. And
I can lie and say it's because, well, it is my favorite. It's like one of my favorite movies, but I did Google real quick when it came out to make sure it met the criteria.
2002.
I had a little bit of time, so I feel bad for Jamie and Katharine. I had a little bit of time to sneak a Google search.
Our last guest is Dr. Daniel Rautio. Dr. Daniel Rautio is a clinical psychologist responsible for the care of patients with BDD at the Specialist Obsessive Compulsive and Related Disorders Clinic in Stockholm, Sweden. He is a postdoctoral researcher in Professor David Mattiak-Cole's team at the Karolinska Institute, and his research mainly focuses on BDD in children and adolescents. Daniel has been in charge of building the clinic's database of young people with BDD, which is one of the largest cohorts of pediatric BDD cases in the world, and has led the first treatment trial evaluating internet-delivered CBT for children and adolescents with BDD. Daniel? Got an answer?
Yeah, and I was going to go with Interstellar. I think it's after 2001. But then I thought I heard someone write that that's a movie that makes unintelligent people feel intelligent. But still, I'll go with that anyway, because I really liked it when I saw it.
Hey, as long as you feel intelligent, it's all that matters, you know? That is the only movie that's been referenced so far that I've seen in full too, and I really liked it.
It's a Christopher Nolan. It's a good film.
Yeah. All right. So enough fun and games. Let's get to the program. So as I mentioned, we've talked about BDD on the show before, but I feel like it's always worth going back and setting the stage before we dive too deep into any particular topics. So for anyone who feels so inclined to answer, what is BDD?
So people with BDD worry that there's something wrong with how they look. They're preoccupied with this. They think about it a lot, that they look ugly, abnormal, deformed. Some use less extreme terms like unattractive, and others use terms like I look like a monster, I look hideous. In reality, people with BDD look normal, so that the flaws that they perceive are not observable to other people, or they're very slight. You know, someone with BDD may say my nostrils are a little uneven, and if you look closely, you may see that they are, but you would never have noticed that, right? Other people would never have noticed that. So they have distorted body image. And then those preoccupations with I look ugly, I don't look right, something's wrong with my skin, it can be any part of the body, trigger repetitive behaviors that, because these thoughts are very upsetting. So people want to do something to alleviate their distress. So they'll try and fix the problem, check it, obtain reassurance about it. So things like excessive mirror checking, excessive grooming, sometimes skin picking, because they're trying to make their skin look better. And then very importantly, the preoccupations with these perceived defects in appearance that to the person with BDD look horrible and to other people aren't noticeable or very minimal. These preoccupations must cause significant emotional distress or significant impairment in day-to-day functioning, like difficulty focusing on schoolwork or not going to school, missing classes, having difficulty with work, difficulty with relationships, because the person thinks they look abnormal. And that last part of the definition is really important because it helps us differentiate BDD, a mental health condition, from more normal concerns with appearance that are very common in the general population.
Yeah. I don't know if anyone else has anything to tack on to that before I ask you to follow up.
I'll just say, as somebody living with it, I mean, Katharine nailed it. I would say one thing is having it, there's also such an emotional charge around your appearance. So although you're having consuming time and thoughts about your appearance, there's also just this feeling of shame, responsibility, guilt, disgust. And so, Dr. Phillips was saying, the last D in BDD stands for disorder. And in addition to really struggling to function, there's also just this constant feeling of dread, embarrassment. And so there's this big sort of emotional charge that people experience around their appearance.
So, you kind of mentioned that there's normally kind of compensatory behaviors that kind of go along with these thoughts. Could you give me just kind of like an outline of what this may look like? Like what sort of behaviors would I find in a population with BDD?
Well, probably the most common is comparing what you don't like on yourself with the same body part on other people. That's a mental ritual because it's not observable. Like we have mental rituals in OCD sometimes, right? Like making lists in your head or that sort of thing, or counting compulsions. So it's comparing with others, and people with BDD almost always think that they look worse. They tend to vastly underestimate their own attractiveness, but they also tend to overestimate the attractiveness of others. Another really common one is checking your reflection in mirrors, but it can be any reflecting surface, windows, the sides of a toaster, the back of a spoon, your cell phone. And these are all problematic behaviors. And they often make people feel worse, like right away. But
Yeah.
that was the mirror checking is really problematic because people already have a distorted view of how they look. And so they're looking and then seeing something that looks horrible to them. That's very distressing behavior. Compulsive grooming. So someone with BDD might get up hours early in the morning because they think their hair doesn't look right, or they have to fix their skin doesn't look right. They have to go through grooming routines, styling their hair over and over again and feeling they don't get it quite right. Spending lots of times perhaps putting on makeup or shaving to get every little last, snippet of their beard gone. Reassurance seeking, like OCD, asking other people, except in OCD, it's not about appearance. It can be about other things. But asking other people, do I look okay? Can you see this on my face? And no matter how reassuring other people are, because they think the person with BDD looks fine, the person with BDD really doesn't believe it because they're seeing something different. And they may think the person's, when they say, oh, you look fine, you look good, that they're just being nice. They're not, they need new glasses. They're not seeing things clearly. Skin picking is a really common one. Skin picking is not always a symptom of BDD, but skin is the most common concern, the most common area of concern in BDD.
Yeah.
Followed by hair and nose, then nose. But skin is most common. It can be anything about the skin, but it's often perceived blemishes or acne or scars. So people with BDD may pick, trying to perfect their skin, get rid of little things. But sometimes this is often a very time-consuming behavior. They sometimes will use sharp implements like tweezers, staple removers, knives, razor blades, and they're not trying to damage their skin. But sometimes they can because it's so hard to stop. These compulsive behaviors are very driven and they're very hard to stop. And so sometimes they actually do damage their skin. So sometimes people with the skin picking actually have noticeable lesions. But it's not intentional self-injury. They don't want to be making, they want to be creating scars or lesions, but they're kind of an exception to the rule that some of them, if they do damage their skin, are an exception to the rule that people with BDD really look normal and often are very attractive people, actually. So those are just some of the compulsive behaviors. It really can be anything, taking excessive selfies, comparing a photo on your phone to another. And these behaviors are intended to reduce distress, but they really don't. And sometimes, I think different from OCD compulsions, sometimes people immediately get more distress and they keep the BDD going. They keep you focused on these negative thoughts about how you look. So when we treat BDD with cognitive behavioral therapy, we really try and help people cut back on all of those compulsive behaviors and get more control over them.
Yeah, another really common behavior is avoidance.
Yes.
So avoidance, like a behavior or a non-behavior. So avoiding and a lot of times it's avoiding social contact or avoiding being close to people where they think the other person might be able to see what they think is defective about their appearance. But it can involve avoiding like certain lighting conditions, covering up certain body parts is like avoiding other people being able to see them, avoiding eye contact. And, in extreme forms, people may avoid going out of their home. Some people become housebound. So, if they're on a video, they may not want to turn on the video. So like avoiding having their face shown or avoiding pictures is really common too.
So I guess like, as I'm hearing these answers, I'm wondering why BDD is separate from OCD and the DSM. And we can talk at length about like whether or not DSM diagnoses really mean that much, but they do end up meaning things in terms of like research and how we kind of categorize people into buckets in research studies. So why, when we look at the DSM, are they separate things?
It's a great question, because there are a lot of similarities between BDD and OCD, like the obsessional preoccupation, the compulsive behaviors, and they are genetically related conditions, but they're also genetically distinct. But there are some important differences between BDD and OCD, and it's really important, I think, that BDD not be misdiagnosed as OCD. Insight in BDD tends to be much poorer than in OCD. So people with BDD are more likely to believe that their fear is true, that they really do look ugly. And I think Dr. Feusner's work has shed a lot of light on why that is. They're probably really seeing something that other people aren't seeing. They're seeing themselves differently. But that insight, people with OCD are much more likely to realize that their fear isn't true. That, if they don't check the stove 30 times before they leave the apartment, will the house really burn down? Well, they worry that it will, but most people with OCD say, well, probably won't really happen.
Yeah.
People
as in BDD.
Yeah. And that's clinically important, because when people with BDD really, believe they really look ugly, they may go and get surgery, a nose job, and that almost never works and can make matters worse. Dermatologic treatment, surgery, dental treatment, etc. It can be harder for them to want mental health treatment and get into treatment, because they think this isn't a mental health problem, this is a physical problem.
Mm-hmm.
So we have to be mindful of that as clinicians and give people hope that mental health treatment can work, because it usually does, medication and or cognitive behavioral therapy. I think some other important differences is BDD there's more depression in BDD, there's more substance use disorders, and I think very importantly, everything we know suggests that there's more suicidality in BDD. So we have to be very mindful of this, because it's very easy to trivialize BDD, because the person looks normal, right? And it's easy to say, oh, you're just vain.
You're overreacting.
No, I mean, most people with BDD have at some point in their life had thoughts that life isn't worth living, that they don't want to be alive. And it's often because of the BDD. And suicide attempts are common, and completed suicide, so tragically, seems to be it's common, not rare. And so you have to be very aware of that. And that's why it's very important, if you or someone else, someone you love, has BDD, it's very important to get them into mental health treatment, because the suicidality is worrisome. And we always have to be carefully ask about that and monitor that during treatment, and make sure that our treatments are improving suicidality. And of course, we want to pay attention to that in OCD.
Yeah.
I think finally, the last thing I would say is although there are other differences too between the two disorders, but the cognitive behavioral therapy is pretty different for BDD. So I think if you there's some elements of cognitive behavioral therapy that are in common between the two disorders, but I think they're quite different treatments. So I think if you treat BDD as if it's just OCD, the cognitive behavioral treatment may not be that successful. So I think that's an important reason to differentiate them, but realize that BDD and OCD often co-occur. So if someone has one of those disorders, be sure to ask about the other. But we want to consider them separate disorders.
If I could just add, Kyle, too, on top of it, I mean, as somebody who has both OCD and BDD, I know on paper it can look the same, but they feel vastly different as an experience. I feel like OCD always felt like something was sort of like potentially causing harm to myself, and I had to kind of protect myself. But BDD always felt like something about me. I felt a lot more egocentric in the sense that I felt value in the things that I was doing. And in fact, most of my distress came from when people were telling me I couldn't do something. When I was in high school, my mom wouldn't buy me a certain skincare product. I am not happy to admit this on camera, but I shoplifted something because I was so desperate. I felt like this was going to be the product that was going to clear my skin. And so it felt like, why are people telling me something's wrong with me when I was in treatment? So to me, it felt very different. It was a lot less insight, like Dr. Phillips was saying. And treating both, the conversations feel very different in session. And so the reason I think it's so important to keep them separate, even though BDD still is an OC related, but the reason we shouldn't just do away with the diagnosis itself is because I feel like one of the mistakes people do take, when they take on BDD clients, is they treat it like OCD with appearance. And like, Dr. Phillips was saying, it's not the same. And so often clients that come and see me have tried therapy for BDD with other clinicians that are good, good meaning, but just treating OCD, and basically when they treat BDD, just kind of replace everything and just change saying BDD instead of OCD, and it's not really effective. And so I think that that's one of the things that we as a SIG and the community is kind of putting out there consistently, is this is a very different disorder with different treatments, and it feels very different when you're treating both or having both. It's important to highlight some of those differences.
Yeah, and it's also, so I think, Kyle, you pointed out that the DSM has some limitations in being able to understand problems that people have, psychiatric problems, and so there are other conditions that also involve obsessive thinking and compulsive behaviors like eating disorders. So particularly anorexia nervosa, and some people with bulimia nervosa, they also have obsessive kind of preoccupations about specific things, related to, it could be body image related, or it could be weight related or food related, and they also often engage in repetitive behaviors as well, that could be related to checking their body, checking their weight, eating food in a very ritualistic way, and so forth. So what I think that it's reflecting, though, is that there's a lot of overlap amongst psychiatric disorders, and so some of the brain mechanisms for a propensity for people to have obsessions and do compulsive behaviors is probably rooted in some of these neural circuits that may be dysfunctioning in a similar way across these disorders.
In addition to their differences, neurobiologically, treatment differences.
Yeah, and then there's and so some there's differences. So for example, OCD and body dysmorphic disorder, even though there haven't been a lot of studies directly comparing them, which I think the field needs, but there have been a few, and so the visual processing abnormalities don't seem to be probably as prominent in OCD, and in particular that one study looked at imbalances in global and local visual processing, and it seemed to not see that in people with OCD, but seeing that in people with BDD.
Which may explain why they have this distorted view of themselves, right?
Yeah.
Their brains are seeing too much detail and not having trouble seeing the big picture, that this is a tiny little thing, not a huge, awful problem.
And then that feeds into the content of what they have obsessions about, and the behaviors that they're trying to do to try to fix it or check it or hide it in some way.
Could you expand a little bit about that finding? Because I find that kind of confusing. Like, are you saying that there's something about the BDD brain that is like fundamentally different in how we process visual information?
There seems to be some indications that can be happening in people with BDD. So studies that have looked at how people with BDD are processing their face when they're looking at their face, or looking at their body, as well, or looking at other people's bodies or faces. So some of the imaging studies have suggested that there's a diminished functioning in part of the brain that is responsible for the overall kind of gestalt of the appearance. So like overall features. And so what probably is happening then, and some indication that there may be basically hyperactivity and hyper scrutiny of details, and the combination of those two, then the model for that is that people with BDD may be seeing things like details and imperfections that are there, because everybody has imperfections, of course, but their brains may not be contextualizing it for them to be able to perceive that whatever they're seeing is actually quite small relative to, say, their whole face or their whole body. And so in a way, it's kind of like it is a magnification that's happening, perhaps, coming from these visual system abnormalities, and then their conscious experience of that is that they're seeing details, but their brain isn't putting it into context. These are actually kind of small and minor relative to like their whole face or whole body.
Yeah, it's just interesting because like that lack of contextualization is also something that I would imagine is the case in OCD. Like, you see something that is misaligned on, to pick a very stereotypic example, like misaligned on the desk, and then that kind of is blown up in proportion to how you perceive the visual scene. You feel anxious and you want to go change it. I'm curious for Katharine and Chris, and then I want to dig into some recent work by Dr. Rautio. Like, why do you think, what cognitive structures are at play that make it so that ERP for OCD just doesn't seem to fit for BDD? Like, to me, like if you took someone with OCD who had low insight, I think you would still just do ERP, right? So why wouldn't it be the same?
Sometimes in OCD, we also do the cognitive therapy, various cognitive interventions. The ritual prevention is very similar in OCD and BDD. We want to help people cut back on those repetitive behaviors like the mirror checking or the excessive grooming, because those behaviors just keep you focused on what it is you don't like, and they almost never alleviate distress, certainly not over the longer term. So the ritual prevention is very similar. We'll have people try and cut back on selfies, and we'll even have them delete some of their most distressing Instagram accounts if they're willing to do that. Mm-hmm. These are just examples. Try and stay out of the mirror. The exposures are similar. We want people to face the avoided situations. In OCD, it might be things they think are contaminated. In BDD, it's usually social situations. But we usually do the exposures more slowly in BDD. There's just so much, as Chris said, these preoccupations are so distressing to people. And I think if you with someone with BDD, if for homework after the first session, you say, go to the mall tonight, they'll probably never come back to see you again, right? Mm-hmm. So I think you have to be a little slower with the exposures. But I think cognitive therapy, which we sometimes do for OCD, I think is always important for BDD to help people recognize the distortions in their thinking, the thinking errors, the cognitive errors that we all make from time to time, but thinking that what someone else is thinking. Like, oh, I know he must be thinking my skin looks horrible today. Mm-hmm. Well, what's the evidence really? And people learn about these so-called cognitive errors that are pretty common in BDD. Fortune telling, I'm going to have a terrible time at that party tonight because my nose looks so awful. Well, can you really foretell the future? And we do some work with self-esteem. I think self-esteem is often very low in BDD. And as Chris was alluding to, it's often about, I'm flawed. I'm flawed as a human. I'm worthless as a person, because the view of how you see yourself sort of extends to you more generally as a human. Mm-hmm. I think one of the most difficult parts of BDD. So we work with that, foster some self-compassion, help people recognize and appreciate other aspects of themselves. BDD kind of takes over and makes you think the only thing that matters is appearance. That's not vanity. That's not vanity, but we help people learn to appreciate other things about themselves. We do some mirror retraining where we help people it's not staring in the mirror. We help them in a very brief exercise learn to develop a more holistic view of themselves, not focusing in on the details, so that when they do catch a glimpse of themselves as they're walking down the street in a reflecting window, or when they do need to look in the mirror briefly each day for a little grooming, they're able to take in the bigger picture to counteract what Dr. Feusner was talking about, which is the excessive focusing on detail. So I think, there are some differences in how we approach.
Yeah, certainly sounds like it.
Yeah, I would say treating both. I mean, I would say that the treatment for body dysmorphic disorder is much more cognitive behavioral therapy heavy than ERP. The goal of ERP is to get people back into the things that they've been avoiding in life due to the BDD. So a lot of people have stopped going to school, they dropped out of work, they're ordering food to be DoorDash to their house because they don't want to go out and order and be seen in person. But like Kathy was saying, is you can't have somebody do that when they fundamentally believe that they're going to walk out their house, they're going to be seen as unattractive, people are going to stare, people are going to judge, and it's going to be such an overwhelming experience, they won't be able to handle that, right? So the cognitive behavioral therapy is important, but even before then, I mean, the number one question we're always going to get in session is, well, you can tell me all these things. I always say, like, coming to my office is usually a last stop, whereas in OCD, it's a first stop. These are people that have tried, going to dermatologists, they've gone to plastic surgery, they've tried camouflaging, they're looking up, online how to improve your appearance. People with muscle dysmorphia are in the gym, they're trying steroids. By the time they get to my office, they've tried everything, and somebody in their life most likely has said, hey, I think you might have this thing, BDD, and they're finally there. So somebody coming in has low insight. Sometimes they don't even want to be in session. So asking someone to go to the mall the first day makes no sense. We're going to use the research that we have. Obviously, Dr. Feusner has led a lot of the charge, but explain to a client, this is why you see yourself differently. This is why every time you ask your family and your friends how you look, they tell you look fine. It's not that they're gaslighting you or lying to you. It's because this is what they're seeing, and this is why you see yourself different. We're really working on motivational interviewing so they see value in making some of that change. And in the cognitive behavioral therapy, we're looking, a lot of times people come in, maybe they have a history of a parent with BDD. That's very common. And so there was this big kind of like culture in the household on appearance and taking care of yourself. I have a lot of clients with that. Or sometimes they were bullied when they're younger. Surprisingly, it's usually not about the feature that they come in to see me, but they had maybe just general bullying or didn't really like how they looked when they were younger. And so I spent a lot of time with a client looking at how is their distorted thinking creating this belief system that there is something fundamentally flawed. And what people usually come out of the cognitive side of it is they're recognizing, like, I have been taking internal thoughts and feelings about my appearance based on what I see in reflective surfaces. And then I've been sort of kind of putting my belief system on everyone else. So if I'm standing in line at Starbucks and somebody giggles at their phone, I'm assuming I'm so hideous, they must have videotaped me and are sending it to their friends and laughing, because I'm projecting my own belief system about my appearance. So people have to understand, like, what's going on in their head that is creating this belief system that they're so flawed. And like Kathy was saying, it's not slightly unattractive. People are coming in desperate because they feel like their outward appearance is inhibiting them from important parts and aspects of their life. So by the time we get to the exposure and response prevention, Kathy also talked about a very important part. Perceptual and mirror retraining is so effective. I can look at old pictures of myself and like them, but at the time when I looked at them before treatment, I really did see these flaws, and clients start to see themselves holistically. So by the time they do go to a mall or whatever exposure they're working on, they are shifting the way that they see the situation. They're recognizing those cognitive errors that are popping up, and they're engaging in values-based activity to really work on kind of like personal connection, because people often isolate. So it feels like a much more like holistic and complex treatment than OCD, but it works, and it helps a lot of people get better. So that's what I'm always pumped about, is letting my clients know there's a lot of people getting better, and they just have to engage in the treatment.
Yeah. Which I hope is a big takeaway for a lot of people in the audience. It is interesting hearing the amount of cognitive work, just kind of reflecting on my own experience in ERP for OCD, and like how little of that sort of cognitive work we did in the process of therapy, which may just be kind of my personal experience. It certainly is just my personal experience. I want to kind of ask kind of more broad epidemiological questions. Tom W. at 1229 asked, are there higher rates of adverse life experiences in BDD that contribute to it? Chris, you kind of alluded that bullying may be seen in a lot of patients. I was wondering if anyone had an answer to this.
Yeah, I'll jump in real quick, then let the panel. Scott Granite and Robin Stern, who are good friends of mine and colleagues, we have this BDD group chat. I know that sounds very nerdy, but one of the things that we kind of talk about is what we see in our clients with BDD versus OCD is there's always like this story, meaning that a lot of people have been bullied. One thing that I see a lot is clients that may have grown up in an area that has a different culture than them, a different race. So they feel like certain features are abnormal to other people. There's a lot of influence from society based on like what are certain attractive norms, and people feel on the outside of it. Social media is really contributing to people having a space to start to like search, compare, and contrast their appearance. Like I said, family members who potentially grow up, obviously on the more genetic side, if you have somebody in your life that has BDD, you're most likely to have it. Now, these things, unless I'm wrong, these things haven't been proven to cause BDD, of course, but we see that can help influence the presentation. So, working with clients that are like, yeah, I went through puberty late. I felt different. People are kind of making fun of me. I always felt like an outsider. That's some of the experiences that I hear from my clients that come in. Now, once again, I just want to highlight that didn't cause the BDD. And in fact, they might have seen signs before that. But there's a lot of stuff that usually clients will say have contributed to why they feel the way they do about their self-esteem and their value and worth.
Mm-hmm.
Yeah, just briefly, quite a few studies have shown, it's a great question, have shown increased risk of childhood adversity, maltreatment, abuse, neglect, compared to people in the general population, compared to people with OCD, interestingly enough. So as Chris said, we can't be certain that that is a contributing risk factor, but it makes sense that for some people it is. But there is no one cause of BDD. Like other psychiatric conditions, there's a pretty big genetic component. It doesn't mean if a family member, a relative, blood relative has BDD that you're going to get it. I know the odds are that you won't, but the risk is increased. And we know there's a genetic component. Life experiences almost certainly play a role. So it's complex in terms of its cause. I think the good news is, though, that to treat it effectively with medication or cognitive behavioral therapy, we don't really need to know the cause. I think hearing what the individual's sense of that is, what some contributing factors may have been, can be helpful for the therapist to know and to work with and keep in mind during the treatment. Yeah, I think the answer to that question was yes. It's probably a risk factor for developing BDD for some people.
And also, I mean, it is, as you mentioned, an empirical question, and it's a question that we have in Sweden, using the Swedish registers, looked into when it comes to OCD, and hope to do it in BDD also. So we can get back to you on that, because it hasn't been done yet, but it's possible. And just to circle back also to the question of suicidality, which we have looked at using the Swedish registers, because that's one of the reasons why prominent researchers go all the way to Sweden, because we have our nationwide registers. We can complement the clinical research that we do, and we see, I mean, at the clinic, I see the same numbers of suicidality as Dr. Phillips gives examples of, that the majority of young people that we treat have examples of suicidality. But what we were able to do, because of a happy circumstance in the diagnostic system, was that we could start to do register-based research on BDD also using the Swedish registers. Mm-hmm. Because in another diagnostic manual, you mentioned DSM-5, but in ICD-10, BDD happens to share the same code as another psychiatric disorder, F45-2 hypochondriasis, which makes it impossible to disentangle in register-based studies. But someone noticed this in Sweden in the 90s and put the letter A next to BDD.
All right.
Which opened up for using the Swedish version of the ICD-10. We could actually start to do register-based studies. So what we did was to extract data on all individuals that ever been diagnosed with BDD in Sweden from 1997 to 2020, which was almost 3,000 cases. And when you looked at the entire cohort, then we could confirm empirically that the risk of self-harm, suicide attempt, and death by suicide is indeed elevated. It's about 3 to 4 times higher than the controls that you compare with, which is people from the general population who has not ever been diagnosed with BDD. You can do different models with different assumptions and adjustments, but you could say that around 4 times higher, which is a significant higher relative risk. And it's hard to do head-to-head comparisons to other psychiatric disorders. We have done recently a big one on OCD, where we managed to include almost 60,000 cases because it was a longer follow-up time. But it seems to be a similar relative risk to other psychiatric disorders. And I think one of the reasons is because we could include all the cases ever diagnosed, both the milder cases, moderate cases, and severe cases, and extreme cases. So the risk is high, but it doesn't seem to be that much different from other psychiatric disorders.
Although other studies suggest that it is higher, and sometimes, you know, the risk of suicidality, not necessarily completed suicide, actual suicide, risk of suicidal ideation and attempts may be higher than in bipolar disorder, unipolar major depressive disorders, OCD. Quite a lot of data would suggest that. So it's, you know, different studies can come to somewhat different conclusions, but I think the bottom line is that in BDD, you know, suicidal thinking, suicide attempts, and actual suicide are quite elevated, and it's something you have to keep in mind as if you have it, as family members, friends. It's just so important to get into good treatment. We've talked a lot about cognitive behavioral therapy, fabulous treatment. It's often extremely helpful. But if you don't mind, Kyle, I have to say something about medication, because it can be life-saving. I've been treating people with medication for over 30 years, people with BDD. We have research data suggesting that, you know, SRIs reduce the risk of suicide, suicidality, not attempts. We didn't have any suicide attempts, fortunately, in the study, or completed suicides, but suicidal thinking, that, you know, Prozac, fluoxetine, for example, and the other SSRIs can reduce that risk. And the medication is just, you know, it helps most people if it's dosed correctly. The serotonin reuptake inhibitors are first-line medication. Fluoxetine, sertraline, escitalopram, and others. Most people tolerate them well. There's a lot of misconceptions about them online. Breaks my heart. You know, fluoxetine, Prozac doesn't cause weight gain, for example. A lot of people think it does. And then we have alternatives. You know, if a medicine doesn't work well, there are others that you can try. We add other medicines in sometimes. And they're not habit forming. They're not addictive. They probably good for you physically because they're anti-inflammatory, right? And they reduce stress hormones in the body. So probably good from a medical perspective as well. So I just want to mention that. And sometimes, you know, CBT can be challenging for people. Sometimes they're too depressed to really participate in CBT. And sometimes medication can help people get well enough that they can actually do the CBT. And we always, for more severe BDD, we always recommend both medicine and cognitive behavioral therapy, both. I think one thing is that the medicines that the serotonin reuptake inhibitors, SRIs, that are our first-line medicine for BDD and OCD are usually underdosed for both disorders. They're usually dosed too low. So that's just something to keep in mind. We often need higher doses than we would use for depression or panic disorder or binge eating disorder, things like that. But they're, you know, it's very important to highlight that in addition to the cognitive behavioral therapy. They're both great treatments.
And of course, and one thing that we need to mention also, that not everyone get access to cognitive behavioral therapy. Right. You have to live close to a specialist unit. And I think that's one of the reasons why internet-based CBT has become so big in Sweden, because we are quite a big country, but it's not that many Swedes. So you can be up far north and drive for 2,000 kilometers before the country ends. So most of us don't live in close proximity to a specialist unit. So, but with internet CBT, which we have now evaluated for adults, and I have done a pilot study for young people, it seemed to help a lot of people. So it's not going to be an alternative for everyone who suffers from BDD, but if we could help half of the people, maybe the more mild to moderate cases. So I think that's a good technical development that has happened over the last years.
Yeah, I saw a number of papers when I was kind of studying up for this live stream about internet-based therapies. Dr. Rautio, could you talk to, like, you know, it doesn't seem as efficacious in the early evidence as in person?
I mean, we published a study in our research group a couple of years ago that did a non-inferiority study to see if this is as good as face-to-face therapy for young people with OCD. And we could show that it wasn't worse, the treatment results for OCD in young people. Worse. It wasn't worse. No one believes that it's going to be better. But the thing is that, I mean, if you live 200 kilometers from the clinic, it may be your only alternative. But I've realized that even young people in the urban capital area, Stockholm, Sweden, they prefer sometimes to do the online therapy because they don't have to skip the whole day of school, and they can do it online instead. And the idea is to give the same treatment. We try to give them the best available evidence-based treatment, but in a different format. So you can see it's kind of an interactive self-help book online with therapy support. So I, as a psychologist, expert on BDD, help them through this program, and they do the same thing as we do in the sessions. We try to have interactive exercises, and they look at video clips, and then they can write to me, and I try to answer within 24 to 48 hours. And doing so, we have piloted in BDD, and with the help of my favorite funder, the IOCDF, we got some money to start a big RCT, which we hope to recruit 154 young people. So we are on our way to test it out, and in the adult population, we have already disseminated it, so it's part of regular care in Stockholm or in Sweden. So you can just self-refer and try the treatment. And obviously, it doesn't help everyone, but it gives everyone potentially access to what we believe are best practice CBT. And even if we only manage to help half of them, we can allocate resources to the ones that doesn't respond to ICBT.
Yeah, I think it's important to have as many different ways that people can get effective treatment as possible.
Yeah.
And so, like, to help people in as many different situations, you know, if they're living very far away, or, you know, like financial in countries where they might have to pay for it out of pocket, like the cost of it is really important. And also, you know, based on their symptoms and their willingness to go in and see a therapist, because some people with BDD, it's really difficult for them to be in an office with somebody else. They have a lot of shame, and it's really anxiety provoking. And they may want to actually start to do it, the internet CBT, because even though they're getting help from a therapist with the messaging, they're not, you know, face to face. And eventually that person, it would be good for the person to be able to get to, you know, do face to face. But that, like, as a starting point, as an entry to get in and to get better and to have as many options as possible. That's what we need right now for BDD, because there's like so little.
Yeah, I agree.
Yeah.
I think it's a wonderful option. The one main big caveat I would have is if someone is a safety risk, if they are thinking they're very, you know, highly suicidal, I think they need personalized attention that, you know, you get in a, it could be online, you know, it could be by video or in person, but I think they need more than an internet-based treatment, which tends to have very little therapist involvement. So we just have to keep those safety risks in mind. And I think the screening process is really important. If someone's more highly suicidal, it may not be the best option. And I don't, and anyway, I'll stop with that. But
What I just wanted to add real quick, I know on the psychologist side, they have PsyPact where clinicians are starting to be able to do telehealth across state lines. I also have a counseling license, and it looks like the compact for us is going to be next year, which will let me work, I think, in like 36 states. So one thing I hope to see is there's an advancement in people being able to access care. And one of the things I want to say quickly is one of the problems I hear from a lot of people is they're seeing a therapist, and all therapists aren't the same, just like all psychiatrists. You absolutely want to make sure that you're working with someone that really understands this disorder and this treatment. Sometimes people ask me, is it better for my loved one to just see any therapist versus being on a waiting list to say someone with BDD? Now, obviously, if somebody has a suicide risk, of course, but a lot of times what I hear is people get ineffective care. And so that's one of the things that we have to work on, as well as medication. I mean, people come in with a lot of, I would say on the BDD side, I know, you know, a lot of us are worried about weight gain. How will this, you know, hair loss? We're looking up online, trying to find out all the ways it's going to impact our appearance. And so one of the things is if you work with a psychiatrist that's informed with BDD, they're going to be able to answer those questions and make you feel much more comfortable. I was very anti-meds based on a lot of the online rumors that Katharine's talking about. I was fortunate to find Dr. Feusner. He was my psychiatrist when I was on medication, but I remember going in very closed off, and him understanding the disorder, speaking that language that I understood, and answering those questions, which then made me go on medication until I went off of it. But it was really helpful. So I think that's one of the things, as Dr. Rautio and other things are starting to advance, we start to work across state lines. One thing I just want to make sure people hear is all therapists aren't the same. All psychiatrists, we don't want to get care with people that are giving much. I think what Dr. Phillips said is so true. I'll have clients coming in that are only on 20 milligrams of Prozac, and they've been on that for 6 years for BDD, not seeing much efficacy. So we have to make sure that people understand dosage and the disorder as well, and train new clinicians as well.
And talking about that, we have added a new project also, which is sort of ICBT for therapists, internet-based training for clinicians, which seem to be promising and well needed. Because another thing that we saw in the first register-based study was that we had way too few cases, less than 3,000, even though we searched for 23 years. And the OCD cohort was 60,000. So it's still massively underdiagnosed. So we still have to raise more awareness. And we also saw that among those who tragically died by suicide, very few cases, only 17. So less than 1% during the follow-up time. But we follow them for an average of 6 years. But most of them had been to an emergency unit before, presenting with self-harm, and most of them who had record of self-harm was diagnosed with BDD at a later point of their life. So we see them at different mental health facilities and emergency unit, and we have to educate healthcare professionals how to screen for this condition.
Screen for it and treat it. It's wonderful you're doing the training. I know Jamie's very involved in training clinicians. Dr. Sabina Wilhelm and Gail Steckity and I published a treatment manual that can be bought on Amazon, right? That someone who knows just the basics about BDD can follow to effectively treat patients. David Veal and Fugan Nezaroglu also published a treatment manual available on Amazon. So I think these are all ways that clinicians, even if they don't have expertise in BDD, can effectively treat BDD. And then the medication treatment's a lot like that of OCD. The main issue being, underdosing those SRIs. That's the big problem. So, but there's a lot of information online and some blogs I've written on the IOCDF website about how to treat BDD with medication. Hopefully, in the aggregate, all of these resources are helpful to people.
Another quick thing about meds too that I often see is that people haven't tried it long enough.
Yes.
Right? So they may have said, their doctor had them try Prozac for 4 weeks, and then it didn't seem to be working, and they switched to another one, and they tried it for 4 weeks, didn't work. So people with BDD often need more like twice that or 3 times that amount of time to be on the medication, sometimes even to start to see symptoms improve.
Yeah, and to get it up to a high enough dose, higher doses typically than we would use for depression on average. And of course, you have to take it every day, but otherwise it won't work, right? So.
Yeah, and it does wonders. I mean, I know for me, it made the BDD thoughts a lot quieter. They're easier to kind of push through. They were less frequent. I felt like I like my brain kind of clicked a little bit. And so I know a lot of times people have a lot of hesitance or worries about both, obviously medication as well as treatment. So if anybody's on the fence watching this, or if there's a family member watching this who has a loved one that's kind of on the fence about treatment, I hope what people hear is that both the medication along with the CBT therapy, people are getting better. I think one of the concerns I hear from a lot of people is they understand with, an eating disorder, these people have to eat and gain some weight. So a lot of hesitance I hear from clients coming in here is, you're going to make me ugly. You're going to make me give up taking care of my appearance. And I'm like, no, this treatment is technically not even really about appearance. Mm-hmm. It's getting you to recognize that you have a mental health condition, which influences the way that you think about yourself, about others, and behave. And I'm really helping to kind of like lift that fog that the BDD's created and the medication as well, to give you a little bit more clarity about what's going on. So I know people are hesitant, but I always say, like I did with Dr. Feusner, just go for an assessment with a psychiatrist, come with questions, go to a therapist, ask. You're not going to be forced to take or do anything day one. So really just come with questions and curiosity, and then, it may change your life for sure.
I I must say, you guys have made this panel exceptionally easy. I had a list of 9 topics that I wanted to cover, and we got to about 2.5. So maybe a part 3 is warranted. I do want to give each of you just 15 seconds. Just if you have some parting words of wisdom you want to tell the community members watching. I'll start with you, Dr. Actually, no, I'll do reverse order this time. Dr. Rautio.
I'll reach out and seek help, professional help if you need it. There is help out there, but you may have to find it yourself because awareness is still low.
And Chris?
Yeah, I'll just say from lived experience, I want people to think you've tried everything. You've gone to dermatologists, you've gone to cosmetic dentists, you've researched stuff, you've altered your appearance, and it hasn't worked. And so I hope one thing that you're willing to try is therapy and medication. It really will be life-changing if you give it that opportunity. So please, 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 even just one assessment can change your life. So,
Katharine?
Yeah, I agree. Just give it a try, right? And have hope. One thing is that most people who have BDD don't realize that they have BDD because they think they really are ugly, even though they're not, right? It's that distorted body image. So if you're someone who's preoccupied, you're really worried about how you look, you think about it a lot, you do these repetitive behaviors, it's affecting your life, especially if other people tell you, that you're attractive or they don't see what you see, you may have BDD. And so just to echo what others have said is get an evaluation from a licensed professional who's familiar with the disorder, a mental health professional. We don't recommend surgery or dermatologic treatment. They seem not to work and can make BDD worse. And the cognitive behavioral therapy and the serotonin reuptake inhibitors, the SSRI medications, can be really so helpful. I tell people if you really stick with the treatment, one thing doesn't work, you try another, you've got about a 90% chance of doing very, very well and getting your life back.
And Dr. Feusner, take us home.
So yeah, no, to add, I agree with everything that people have been saying, and I really want to also convey that idea about the hope and how many people I've seen get better, how many people I've seen that have come in and had poor insight and were really suffering a lot and got to a point where they are leading quality lives and the symptoms are minimal and it's really like getting your life back. And I would to add to that also to consider the possibility that you may not be seeing about yourself the same way that other people see you, because our brain really creates what we see. And if it's not functioning right, then we may be seeing something that is really not there.
That's a good philosophical point to end on. I definitely want to have a part 3 as well, because I still haven't heard any updates from the Barbie movie controversy that started this whole stream, but we'll have to get to it next time. I do also want to amend something I said in the beginning of the stream. So applications, the request for proposal is live now. If you want research funding through the ICDF, so you can go check out the request for the proposals. You can see the details and instructions for asking for research funding through the ICDF now, and then applications will be accepted on January 6th. That's the information I was muddling through at the very beginning of the stream. Thank you to all our panelists for joining. I have to go to another class, but yeah, thank you all. It's been a lot of fun. I've learned a lot.
Thanks, everybody. Thanks for
Thanks.
inviting me.
Thank you so much.